YouTube.
Okay.
Yeah. The YouTube. Okay, guys, we are live on the YouTube. Mega. Yeah. Hello, Mega. We are live on the. Okay, guys, we are live on the YouTube. Mega.
Dr. Shiv, can you enable my share screen, please?
Yeah, we can share screen.
Yeah.
So
Hello,
Mega. Welcome, welcome everyone. Live on the. Okay, guys, we are live on the YouTube.
There is lag. Some.
Yeah, I have actually. That was my YouTube, which was.
You need to enable my share screen, please.
Oh yes, yeah, we need to do that. It's all now it is all share screen.
Yes, it is.
So, welcome everyone.
So, are we on, Dr. Shiv? Yeah?
You're on, yes, you're on.
Great. So thank you, Dr. Shiv, for celebrating this World Hospice and Palliative Care Day with all of us, because palliative care is essentially a part of the anesthesia only, and mostly the anesthesiologists are further specializing into palliative care. Me, myself, being an anesthesiologist, so anesthesia is really close to my heart. And so here we are celebrating World Hospice and Palliative Care Day with all of you guys. And so it is celebrated on second Saturday of October. This time it happens to be October 10th, 2020. And the theme this time is My Care, My Comfort, which is actually the essence of all the healthcare system, right? All the patients who come to us, they come for care and comfort. So it is the essence of where we are. So let me just tell you about this very beautiful symbol that they have given for us. So there are two hearts in there, which actually signify the bond between people who are accessing care and their loved ones. So, and these hearts also symbolize what palliative care offers to healthcare in any healthcare setting. Palliative care offers us resilience. It offers us tools to support someone who's experiencing pain, distress, and uncertainty. It offers, in addition, support for the family members in grief and even after the patient or their loved one is gone in their bereavement process. So these are the two hearts which are joined together. They seem like a butterfly, which symbolizes transformation, hope, life, and spirit. They also kind of form an infinity loop to signify the infinite bond that the patient and their loved ones they share. And completing this symbol is the circle. Circle is actually signifies the healthcare system that we are all in. And this is where the word palliative comes from. The word pallium, the root word for palliative, which means a cloak or a shield, right? So that is how this symbol is formed, very beautifully created. And thank you so much for giving this opportunity. I would now like to invite Dr. Abhijit, Dr. Summer. So Dr. Summer is an associate professor and in charge pain and palliative care division at Department of Anesthesiology, AIIMS, Raipur, India. So over to you, Dr. Summer, please. I'm stopping my screen share.
Thank you, Dr. Megha and Shiv sir and everyone for the opportunity. My slides are visible to all of you. For next few minutes, I'll be talking about the concept of palliative care, and on the occasion of World Hospice and Palliative Care Day. So the learning points from this talk would be, I'll talk briefly about the history of palliative care and what is palliative care, why we need palliative care, and what are the basic principles of palliative care, and what are the different models of palliative care, and what is the holistic assessment, and the interdisciplinary team of palliative care. So if we go to the history of palliative care, so the lady in the picture, Dame Cecily Mary Saunders, a nurse, a social worker, a physician, who is the pioneer of the hospice movement, and who actually tried to emphasize on the importance of palliative care in the modern medicine, to integrate it with the modern medicine. He established the first hospice in Saint Christopher's Hospice in 1967, and until 1980s, the hospice and the palliative care were considered as same, when the hospital-based palliative care programs were developed in Cleveland Clinic and Medical College of Wisconsin. In India also, the movement carried on, and Shanti Avedana Sadan was the first modern hospice which was established in Mumbai in 1986. So if we go to the timeline of the development of palliative care, the upper part, the blue part is the international timeline, and the green part is the Indian timeline. So if, as I have already said, in 1967, the St. Christopher's Hospice was established and followed by in various places. And 1987, the hospice bulletin was released, and it gained popularity. International acclaim was there. And in 2006, US American Board of Specialties, they recognized hospice and palliative care as a subspecialty. However, in 2010, there were a lot of shortage of MD palliative medicine, and they were in the need for palliative care specialists. If we come to Indian timeline, 1975, where the National Cancer Program started, and from then there was no looking back. In 1984, modified National Cancer Program pain relief was started. And again, in 1986, the Shanti Avedana Ashram in Mumbai was established. In 1993, Pain and Palliative Care Society was established. In 1994, Indian Association of Palliative Care, focusing on palliative care per se, was established. Then 2001, National Neighboring Network on Palliative Care. 2003, Pallium India by Rajagopal sir. And 2008, Kerala State Palliative Care Policy was proposed. In 2012, Maharashtra had a state policy, and the major development in palliative care movement in India was in 2014, where the NDPS amendment, the Narcotic Drugs and Psychotropic Substance Amendment, was modified, and morphine was tried to made available in every corner for better pain relief. In 2016, the Indian Association of Palliative Care in Pune, the national conference, there was a Pune declaration where the society has urged to the government of India to give a rightful place of palliative care in the non-communicable disease list. So, and then now on, everywhere in government setup, in private setup, the palliative care has been identified, and we are now growing big in each specialties, not only anesthesia. We are trying to take, it is an interdisciplinary approach. So we are trying to take other disciplines also with us, so that the palliative care is provided to the needy. Now, what is palliative care? In a simple word, that to palliate means to reduce the violence of a disease, also to ease without curing the underlying disease. So palliative care, it treats, it prevents or relieves the symptoms of a serious or life-threatening illness, but it does not cure it. Now, WHO defines palliative care as an approach which improves the quality of life of patients and families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification, impeccable assessment, and treatment of pain and other problems like physical, psychosocial, and spiritual. So there are many important words in this definition. Like palliative care is focusing on improving the quality of life of the patients and the families. So it is taking the patients and the families together and trying to sort out the issues related to the patient as well as the families, and trying to reduce the suffering of the patients and the families. American Association of Hospice and Palliative Medicine also gives a definition, which is more or less like WHO definition. Like it is a comprehensive specialized care provided by interdisciplinary team to the patients and families living with a life-threatening or severe advanced illness expected to progress towards dying, and where care is particularly focused on alleviating suffering and promoting quality of life. The major concerns are pain and symptom management, information sharing, which is very important in this regard, and advanced care planning, psychosocial and spiritual support, and coordination of care. So the palliative care does not say that no, with the curative or the other treatment cannot go hand in hand. So it can go hand in hand, as well as palliative care also can be supportive to that. Now, why do we need palliative care? As our longevity is increasing, the aging population is increasing. So the rise of burden of non-communicable diseases are increasing. So most of us, or most of the non-palliative care specialists, they would think that it is only related to cancer. So it is not so. It is also for the other chronic illnesses, like for example, HIV or chronic infections, neurological diseases like COPD, chronic heart failure, chronic kidney diseases. Palliative care also cares for those. Each year, an estimated 40 million people are in need of palliative care. Now, 78% of them, those people, they live in low and middle income countries. That means they are devoid of getting palliative care in those countries. Now, worldwide, only 14% of those who need palliative care, they currently receive it. So the number is pretty less, and we are. That's why every year in World Hospice and Palliative Care Day, we try to increase the awareness of palliative care so that the number increases and the care also increases. Now, in India, the scenario is more or this is a data from 2013. I'm sure we have improved upon that. So estimated 34 million people, they need palliative care in the country, and less than 1% have access to palliative care. So this, we need to work on that, and so that the number we can try to increase. 75% of the 8 lakh new cancer cases per year are diagnosed at very late stage, rendering it to not treatable or advanced stage, so that those patients who are in need of palliative care can be provided. But less than 3% of India's cancer patients, they have access to adequate pain relief due to the strict morphine policy. But however, thanks to the NDPS amendment, where RMI, the Recognized Medical Institute Act, has come, where the morphine is being made available to the needy patients. Now, lack of knowledge among healthcare professionals and public is one of the very important factors where we are it's the most important barrier where palliative care is not outreaching the needy. So coming to the principles of palliative care, so the basic principles of palliative care, the approach, it provides relief from pain and other distressing symptoms. So it affirms life and regards dying as a normal process. It is not palliative care does not try to intend neither to hasten or postpone death. Like an 86-year-old COPD patient who has been visiting emergency every month and going into respiratory failure, and there is no advanced care planning, and we put the patient on ventilator without even discussing with the family what do they want, and patient dies after 7 days. So we're just prolonging the death without discussing the prognosis. So palliative care does not do that. Palliative care integrates the psychosocial and spiritual aspects of the patient care. It does not see the patient as a diagnosis or a bed number or a disease per se. It also respects the patient's psychosocial and spiritual aspects. It offers a support system to help patients live as actively as possible until death. It will enhance the quality of life and may also positively influence the course of illness. So palliative care is applicable early in the course of illness in conjunction with other therapies that are intended to prolong life, such as chemotherapy or radiation therapy, and it will include those investigations needed to better understand and manage distressing clinical complications. So it offers support system to help the family cope during the patient's illness and in their own bereavement. Palliative care uses a team approach to address the needs of the patients and also their families, including bereavement counseling if indicated. So these are the principles of basic principles of palliative care. So when does the palliative care start? This is very important because most of the healthcare professionals and also public, they do not have the idea that palliative care can go hand in hand with the when the disease is detected. So the upper part is the old care model where initially the disease-directed care is there when there is no hope, palliative care comes into action, and then the hospice care or let's say the end-of-life care. But the model has been modified and changed. Now you can see here that when the disease is being diagnosed, palliative care can go hand in hand with disease-directed care. It does not hamper the disease-directed care, but it supports with the when the active therapy is going on. But there is a point of time when there is advancement of the disease, and if the disease course is such that the patient goes into advancement and there is incurable stage, so there comes the hospice care. Now, it does not end with the death of the patient. It also provides grief and bereavement services to the family to cope up the loss. So palliative care basically it starts with the diagnosis and it continues till death. Even after death, also bereavement services are continued. So in a curative model, if we talk about a curative model, cure is the ultimate goal. But palliative care, the cure is not the ultimate goal. The other goals are being addressed, like for example, relief of suffering, control of symptoms, restoration of functional health, psychosocial aspects, spiritual aspects. Other goals are being addressed in palliative care. In curative model, death is the failure of medicine, and if the patient is uncurable, there is loss of hope. Whereas in palliative care, there is no loss of hope. Hope is affirmed, and the death is planned, and the death should be dignified and painless and symptom-free. So in a study of preference, if of preference of death, like most of us, we talk about what are you going to do? We have a plan. If COVID was not there, we would have planned for vacation next year, where to go. But none of us will plan about where will we die. The place of death is very important because in India, we are still working on it. Like there is advanced care planning. The last wishes of the patient are not being addressed. So in Kulkarni et al., they found that majority of the respondents in that study, 83%, they prefer to die at home. So whereas sadly, most of the patients, they will die in ICU, out, away from the family members, on ventilator, a painful death. So we need to work on it and have policies so that the patient have a peaceful death and preferably at home. Now, what are the types of palliative care? So primary palliative care and specialist palliative care. Primary palliative care, it can be anybody. It need not be an anesthesiologist or a palliative care trained personnel, a medical nursing or allied health professional who provides primary care with palliative approach. So it is an approach to all the patients with life-limiting illness. So you need not be a palliative care specialist for that. But specialist palliative care who has a who has been trained by a recognized accrediting body, and it is an interdisciplinary team of specialist palliative care professionals. They are the specialist palliative care. The specialist palliative care, they work in three key ways. They provide direct care to referred patients with complex needs. Like they know that, yes, this is the center for palliative care. So they'll contact you directly and you address the problems and try to provide the care. And it can provide consultation to the patient being cared by the primary care providers, like other departments, like from orthopedic department, like oncology department, they are getting referred to the palliative care team. It also provides support and education to services providing end-of-life care, like to the critical care units, surgical critical care units. They can provide services of end-of-life care. So there are different models of palliative care, like hospice care. Hospice care is a well-established program. It has started long back to provide patients with a prognosis of 6 months or less. It is more or less like there is the patient's the disease has advanced to a stage where the 6 months or less of time is left for the patient. Hospice care can be provided. However, the hospice care and the palliative care, they work on the same principle. Now, palliative care programs, they are institution-based programs in the hospital or nursing home to serve the patients with life-threatening or life-limiting illness. They occur in the hospital settings by unskilled nursing facilities. They provide services to the patients anywhere along the disease continuum between the initial diagnosis and death. So as I said, that the palliative care starts with the diagnosis of the patient along with the curative or the disease-directed care, but hospice care is at the last part of the life. There can be outpatient palliative care programs for ambulatory patients who can come to your OPD time to time. And then comes the community palliative care program or the outreach or the home care program where they collaborate together, the home care team, to support the chronically ill and seriously ill patients who need not come to the patient. The team can visit home and time to time and provide the palliative care. So the holistic approach or the total approach is like when in any medicine OPD or surgical OPD, the patient comes, we see the patient as a diagnosis, like we see only the physical part. We intend to ignore probably because of various factors, the social factor, the emotional factor, the spiritual factor. So physical factor is very important, yes, agreed, but social factor like whether the patient is afraid of loss of role in the society or participation issues or any distress over family members or career, all those things has to be addressed. The emotional component is very important. That has to be whether the patient is anxious or depressed or frustrated or is there hopelessness, that has to be addressed. Spiritual issues like whether the patient is in guilt or any fear that what happens after the death or any sense of connectedness is there, that has to be addressed. The holistic approach is what it completes the patient care, not only the physical approach, it can include the social, emotional, and spiritual approach. For the interdisciplinary palliative care team, it includes a whole lot of members. I'll start with the volunteers because these are the most important team members in interdisciplinary palliative care team, because they are the one who will actually popularize palliative care in the community. So volunteers need not be a healthcare professional. They can be a shop owner. They can be anybody basically from the community who actually will be informing you or helping you to connect with the patients. There can be physicians from any department who are trained in palliative care or primary palliative care physicians, nurses who are trained, social workers, physiotherapists, occupational therapists, clinical psychologists, pharmacists, and the list goes on. So the interdisciplinary approach of palliative care, which will help reducing the suffering and restoration of functional capacity of the patient. So the responsibilities of various dimensions. The physical dimension can be taken care by physicians, nursing, treating, and prescribing can be done. Psychological, sometimes being available and listening to the patient is very important. Patient might be wanted to tell you something, but we are just writing the diagnosis and sending the patient to CT, MRI, and planning for surgery. And after that, what? After 6 months, the patient died. So listening to the patient, whether he has any last wish to fulfill or any other plan or any will to be completed for him. Some sort of counseling can be done. Those patients, like telling the patient about the plan. The social component, we can the social worker can evaluate the financial status. If the patient is the only breadwinner of the family, the backup has to be identified. The family support is there or not, whether the patient needs any other social help, that has to be identified. Spiritual support, we need to respect the spiritual aspect of the patient, whether the patient believes in prayer or counseling and carrying out some rituals or rites. Like you will see most of the ICUs these days, I used to work in Shillong before. I used to see that that if we declare that the patient is not going to make it, so they will call the father from church and they will try to pray. So we used to allow that because we have to respect the spiritual aspect. And the family believes that if we do that, the person who is leaving us will be at peace. So we need to respect those decisions at times, and most of the times, basically. I'll conclude my talk with one quote by Cicely Saunders. You matter because you are you, and you matter to the end of your life. And we will do all we can, not only to help you die peacefully, but also to live until you die. It is important from all of us who are listening to the talk, because at any point of time, each of us will be needing palliative care. So if we do not understand the fact now, we need to popularize palliative care and outreach everybody, for us, for our family members, and for everybody, that palliative care is there to support you to die with dignity and peacefully. Thank you.
That's excellent, Samarjit. We can stop sharing his screen, and I would request other faculties to come in, and we can have a little discussion. Or anybody wants to add anything? I mean, that was obviously a very good introduction to the palliative care.
Yes.
Yeah.
Indeed.
Yeah. Mega and Abhijit, or anybody wants to add anything to what Samarjit actually has said about the palliative care? It's
I think it was absolutely wonderful the way Dr. Summer mentioned about it. Just give me a second. Yeah. Thank you, Dr. Summer, for such an elaborate and beautifully presenting what palliative care is all about. And Dr. Shiv, do we have any questions on YouTube? Do we want to take something?
no, it's there. I don't see any questions yet, so
Okay.
I think we can go ahead with your lecture.
Sure.
Well, this is going to be a
So,
different kind of a lecture. Not really a lecture, isn't it?
great.
Right. So, good evening, and to continue this celebration of World Hospice and Palliative Care Day, we'll be talking something about communication. So, first, before starting, can we differentiate between talking and communication? So, that is what we will be focusing on, with the essence of the difference in between two. When both the parties are participating into listening and hearing, we call it communication. So that is a very important aspect. So let's start communicating about palliative care. Let's start communicating about communication. Let's initiate communication with our patients. So common scenarios where our communication is needed is once when we are giving a diagnosis or a bad news to a patient, or communicating prognosis when we are called into a difficult scenario, or a position where there is a change in goals of in the treatment of patient's journey, and explaining complex medical information, or sometimes when the advanced directives are to be talked about, and we need to discuss about the code status of the patient, and talking about maybe dying, loss, grief, or at last when we are pronouncing death, or when we are communicating even after death to the patient, like Dr. Samajit mentioned, as a part of bereavement. So these are some of the important aspects where we need to communicate, not just talk. So when we talk of communication in palliative care, these are the important domains where we need to focus on, is the structure and the process of communication, the physical aspects of care which we need to convey to the patient and their family, and there is a psychological and psychiatric aspects of care, and sometimes the social aspects are more important. And when there are other aspects of spiritual, existential, and religious aspects which are more important to the patient and the present situation, and sometimes the cultural aspects are to be kept in mind when we are communicating to the patient or the family. And all these, and this should continue till the patient is at end of life. And of course we should be aware of our ethical and legal aspects of palliative care or end of life care, which might differ from various locations. So in India it might be different from what is allowed, and what how the things should be, whether when we are providing end of life care, what we are doing, whether it is withdrawing, whether it is withholding care, or whether it is about the things which legally are allowed in our setup. So these things should be kept in mind. Administratively also, different hospitals might have their own policies about end of life care. And unfortunately, as health is a state subject in India, so we don't have a national uh, policy. We might have few of the states in India, they have their own palliative care policies. So Delhi is not, at the moment, is not having a palliative care policy. And last year, All India Institute of Medical Sciences, they announced their end of life care policy. So there are few landmark changes which have been happening since last March 2018, the announcement of the advanced directive by Supreme Court. So, with all due respects to my colleagues and my oncologists whom I work with, so I feel that there are certain barriers faced, not exactly because of the nature of their work, but because it is difficult. It is not, I mean, people are different. It is not easy for everybody to talk about palliative care. Maybe it is because of the physician's barrier, or it might be due to a certain situation in which the patient is landing into. And it is not easy to talk about death and dying to everybody. You might land up into a difficult communication scenario, but as you grow, as you communicate, as you learn, you would go back and think about each scenario, and maybe you can improvise the next time better. So lack of experience is one thing. I mean, even if I talk about myself and my communication, I was not taught communication as a part of our curriculum, but there have been changes. I've been informed that there has been a module on communication and palliative care now, as directed by MCI into undergraduate curriculum. So, and we used to learn communication as we used to grow up in hierarchy. So, but now I hope that the things might change with that module. And team dynamics and responsibilities also changes. As a part of an oncology team, I here play a role of maybe even making sure that the things are more in matter, in complete comfortable for both the doctor's party, who is a junior doctor who is going to give a 24-hour coverage for the oncology team, and for the patient's comfort also, that to make sure that if something is happening at odd hours, so the patient's side is also heard of. So that also depends on, and also there is, in India, it is not seemed very appropriate to talk about death. And the situation is changing, I would say. Now we have people coming from different parts of continents and taking care of their family members in India, and they are aware of what is palliative care and what are their rights in terms of uh, taking care of a patient in a hospital, or would they want to continue the home care at the place of their choice. Like Samar mentioned, that the place is only one of the decisions which you decide when you're talking about hospice care or palliative care at the end of life. So now we'll be, me and Dr. Megha will be enacting a role play. So the case is where the patient has received chemotherapy as a part of initial plan of his oral cancer, and on subsequent re-evaluation, when he was due for his surgery, or maybe further decision to decide whether he is fit for surgery or not. He has presented with a progressive disease. The disease for which he was receiving chemotherapy has progressed, and there is a pain which is also associated with some of the most common symptoms which we see in oral cancer is pain which is radiating to head and ear and associated with poor oral hygiene and poor foul smelling breath. So this is a scenario. We'll first enact how it is usually done. I am not pointing fingers at anybody. We are just enacting how it is. If you take as a routine practice what is usually being done, and then how can we improvise and how can we go back and inculcate few of the learnings, and then we see how ideal scenario or maybe near to ideal scenario we can do in our settings.
Let's go. So I'll be acting as a doctor, okay? Dr. Gaurav would be the patient. There we go. Yeah. So
Mega, we need to stop sharing the screen first so that
yes.
whole screen is available.
Or maybe
Yeah, stop.
not sure.
That's it. Yeah.
Good morning, doctor.
Yes, Mr.
Anand.
Mr. Anand. Yeah. Tell me, what is it?
I was due for my scans, and I hope that if you can have a look at them.
Yeah. Sorry.
You can tell me what about it.
Okay. Yeah. I remember. You were due for your PET scan, yeah?
Yes,
Okay.
these are my PET scan results, and then you advised a biopsy.
Okay. Oh. Mr. Anand, actually, but the scan shows a progression in the disease. So you have completed your 6 cycles of neoadjuvant chemo. You completed your 6 cycles, yeah?
Yes, ma'am. Yes.
And I think we thought about surgery the other time.
Yes. Ma'am.
Oh, yes. So, look, Mr. Anand, I don't think we will be able to go ahead with surgery in your case because the disease has actually increased. So, I think I'll just pen down a few more tests for you, and you can get back with the reports. Yeah.
So,
Okay.
when do I see you next?
I think with the reports, yeah.
And when would be my surgery?
As I told you, I don't think we can go ahead with surgery anyway. So we might need to go further with chemo or radiations. I'm not sure if you are still eligible for that surgery.
So when do I come back?
Yeah, hello? Yeah. Just wait for 5 minutes, huh? I'll be back. Yeah, come on. Yeah, so?
When do I contact you again?
Yeah, sure. I can get back with these reports, yeah?
Okay, in OPD only.
Yeah, OPD, you can take appointment from my coordinator and she will guide you.
Okay. And how do you think this surgery would be postponed to?
Look, we don't think we will be able to plan you for surgery. I think chemo would be next, but you please get these scans, these reports done, and then only we'll talk about further treatment. Okay?
Okay, thank you.
So this was the scenario in a busy medical oncologist OPD because we sometimes do not have time to really, address those issues that the patient might be having at that point. I'll just share my screen one more time. Okay, so So this is a kind of a scenario when a patient was, after his neoadjuvant chemotherapy, the patient was planned for surgery, and but after evaluation of the scans, the disease has progressed and he can no longer undergo a surgery, which was supposed to be the curative management for the patient. However, now the goals changed, and he would probably go in for a palliative kind of chemo, and not a definitive treatment. So, in fact, Buckman et al. In 1992, they gave this very nice, acronym, how to break a bad news for the patient, which goes like spikes. So here there is setting as to you must prepare in advance, right? Whenever I know that one of my patients who has progressed, who might have progressed, so I would usually discuss the scans, and the patient has undergone a PET scan. So we usually discuss our PET scans in advance with our nuclear medicine people, so that when the patient comes in, I would know in advance how are the things happening, and there is progression, right? Then we must select proper environment. The environment overall in this scenario that we show was okay. We were both sitting on our chairs, and the patient was comfortably sitting. Although I would say here, probably when we give a bad news, usually the patient should be accompanied by an attendant. You should not tell such things alone to the patient. So that setting thing should be there. Then we have to must ask about perception as to what the patient already knows. The patient might have discussed these scans while he was taking those. He might have read it himself, or might have discussed it with a few of his known doctors or other doctors. So always ask patient, what have you discussed it? Do you know? Do you know what is there in your scan? So always ask what the patient already knows about the disease. Then invitation. So not all the patients are like they want to know everything. Not all patients would be like that. There would be some patients who would say, okay, just tell me the overall picture. I don't want to know the details. Then there would be some patients who would say, I want to know the exact details. They would even like to see the scans and see those lightning areas in the PET scan. So there are different kinds of patients, and we can we can ask the patient, what would you like to know, and would you like to know the entire thing in detail? So and the patients would usually respond to this question. And only after we have seen that what does the patient know and what the patient wants to know, that you actually come over to giving the bad news. That is the knowledge, right? So before actually breaking the bad news, we have covered 3 points. That is very important here. So again, share the information very clearly. Mostly do not use any medical jargons with the patient that they do not understand, and don't keep going around the bush. Say it clearly. Say it as the matter of fact that the disease has progressed, that your cancer, the results that we were expecting are not there, and the cancer is growing. So in whatever language the patient understands, tell them, right? And actively listen to them. When we say active listening, we kind of let the patient speak, right? So in the conversation that we just had, most of the time the doctor was speaking, right? So it's a 90-10 principle. 90% of the talking should be done by the patient, and 10% should be done by the doctor. However, here the scenario was entirely different, and I was doing most of the talking and just telling the patient about it, and not letting the patient actually ask what he wanted to. He might have had pain and other symptoms, so which he could actually not communicate to me because I probably did not seem interested in those. And active listening also says about how you sit. So if I'm sitting like this and talking to the patient, okay, And if you could notice, I was fiddling with my phone. I did receive 2-3 calls in between. So all those things are really important when I know when I'm anticipating a difficult discussion and communication with the patient. I can try and put my phone on mute for 10 minutes, or I can give my phone to my coordinator to attend any urgent calls, right? And always sit like open hands, and so that gives an indication that you are inviting the patient to talk to you, right? If I sit like this, seems like I don't want. These are the non-verbal clues that we give to the patient. So so these are the things that we must pay attention to when we are talking to a patient. Then another important step is which sometimes we as doctors, kind of skip through very quickly, is empathizing. That when the patient has had that thing, you have actually given that information. So the patient might, sometimes there can be different things that the patient may throw at that time, So patient can say, why, what, it cannot happen. I have been taking my chemos on time. It cannot happen to me. That's denial. Or the patient might become angry. That how can it happen to me? So we need to deal all those things in different ways. But the patient might cry. So all those things, we must give time for the patient to express his emotions and empathize with them. Empathize, let me go to my next slide. How do we show empathy, right? So there are non-verbal clues of showing empathy as to how do we, if I'm maintaining eye contact with the patient. So there can be, sometimes you should also take cultural clues as to if you should maintain eye contact or not. There can be certain cultures where the patient might not like to maintain eye contact with you. Then we should both be sitting always, like if I go to ward and discuss the scans, I cannot be standing over the head of the patient and the patient is lying on a couch and standing over, I'm telling what is there in the scan. Always pull a chair and sit by the side of the patient whenever you tell the patient about it. Face the patient, right? So like I'm sitting here and the patient is way far apart, not really facing. So face the patient when you're telling such important thing. Open body posture, I already told. Then leaning towards the patient. If I'm talking to a patient, if I am towards the patient feels that I'm interested. If I lean back and try to be away from the patient feels that the doctor is not interested and is not really empathizing. So I should be relaxed without any tensions, like tensions about calls or any further upcoming meetings. So I must give, usually these conversations will take say around 15 to 20 minutes at least in my clinical scenario, or maybe sometimes even more. So put aside your things and start the conversation only when you have time, right? So you cannot really rush through these conversations. And touch again. So in Indian context, usually an opposite gender would not touch the patient, and so but sometimes when you're involved, you can give a light pat on the shoulder or a light touch on the forearm might not be taken as wrong indications to your empathizing. So these are the non-verbal clues. Then there are certain verbal clues that we can use at this point, which is beautifully given by the acronym NURSE, as to name it. As in when the patient said, what is it? So you can acknowledge what the patient is feeling. I can see that you are upset about it, or I can see that you're crying and you don't feel very good about the test results. So such things, right? And understanding. Then something like, I understand it is so difficult for you that you were planned for the surgery and now the surgery cannot happen. So I understand it must be hard on you. Something like this. Respecting. So like if it's a caregiver who's coming in and they have been taking care of their mother for long, who has been a cancer patient. So respect them, say something that I'm so impressed by the type of care that you have been providing to your mother. it is so nice of you to do that to her. I'm sure she feels the same way for you. So respect that. Support. Then never ever, this is very, very important. And this is what actually the patients are afraid of, abandonment. So always say that we are there for you. Our team is there for you. Don't take the onus on your own self, but again, because one person cannot be there 24/7. So our team is there for you. We are always here for you, and focus on more positive things that will again come over it. So focusing on goal setting and positive things, these are the ways how to handle these situations. And explore, it always comes in handy, this word, tell me more about. So that kind of changes the things from the patient might like to share certain things as to he has a young daughter at home, and those things. And so tell me more about your family. How do you think your parents would take it? Those things you can explore more about it. So once we have empathized and given the patient time to express his emotions, then we come over to summarize. So always, whenever the patient is so emotionally charged, the patient might not have absorbed all the information that you have really given in. So give them some time, and then at the end of it, summarize it. Okay, so I think could you understand what I said? That the scans are showing progression in disease, and we might not be able to go in for surgery at this point, and you might need some more chemotherapies. So something like this, and review the treatment options. As I said, goal setting. So we will introduce you to our palliative care specialist, and we will introduce you to our social worker and those things. So, and schedule a follow-up. They should always, then you should always give time, okay, see me after 7 days, and then we further plan your further treatment, right? So next, we come over to the same scenario again. And there we go for the role play. We hope to do better this time. Okay, let's go.
Excellent.
Okay.
Gaurav, come in.
Yeah. Oh, hello, Mr. Anand. How have you been?
I'm fine, ma'am. Thank you.
Oh, please sit. Please take your seat. So, how are you doing today?
I'm feeling a bit of pain in my lower jaw, and it hurts when I eat something. I'm mostly taking liquids, but it is hurting a lot.
Oh, I can see. I can see you are in a lot of pain. Okay. So, how's your sleep?
Mostly it is fine, but when I have to take pain medications before I sleep, it is fine. But sometimes if I skip, it disturbs my sleep.
Okay. So I think we will I will prescribe you some medications for that. I'm sure your pain will be much
Yes,
better.
ma'am, but I think you should go over these reports first.
Oh, yes, of course. Yeah, I absolutely remember that you were due for a PET scans, and in fact, I have discussed those with my nuclear medicine specialist. So, Mr. Anand, is there anyone else with you accompanying you today?
Oh, usually my wife accompanies me, but today she's taking care of a baby, so she's not here. I'm on my own.
Oh, that's okay. And did you get a chance to discuss these reports with someone?
No, I haven't discussed it with someone, but yes, I did go through them, and it looks a bit scary to me when they mention on this page that the disease has progressed.
Yeah. So, Mr. Anand, would you like to discuss these scan reports right now, since nobody's accompanying you?
No,
today?
it's perfectly fine. I've come all across for this only. I want to discuss the reports. And I have this scan also. Can you show me where is my tumor?
Yes, of course. So, look, Mr. Anand, so there are a few patients, who like to know the entire thing. And there are a few patients who would not, who would just like to know the bigger
I
picture.
like to know everything.
Sure, I respect that. So, all right. So, as I discussed your scans with Dr. Anupam, who is our nuclear medicine specialist here, and I am really afraid to tell you that the scan reports are not very reassuring.
Is that means that I'm not going to have my surgery?
Um, in fact, we did discuss about your case and in our tumor board meeting, and I had a word with our surgical oncologist, head and neck, and he is of opinion that he will not be able to operate on you right now.
Oh, and when do you think it would be possible?
This it's not really possible for me to let you know about that right now. We might need to give you a few more chemotherapies on this.
Okay. And what about this pain which I'm having?
Just don't worry about the pain. I'm sure we can handle that. I will refer you to our pain and palliative care expert. They are just absolutely amazing at it, and you will be absolutely fine in terms of pain.
Okay. That's reassuring.
Yeah. So is there anything else you would like to discuss?
I think my wife would also like to know more about these scans, and she would like to know this because I think I would need your help in disclosing these results to her. So would that be a possibility?
Yes, absolutely. We will be happy to do that with you. We can do that together. And whenever she feels like she can come in here, or if you want somehow, anyhow, we would be absolutely happy to help you that way. Yes. So
Okay.
I understand this would be hard on you.
Yes, but I think your treatment this time would work and I'll be able to get my surgery.
Mr. Anand, I think I wish this was the case, but we need to see by giving you more chemos. But mostly this does not happen, and with the disease progression like this, I am not sure if we will be able to do a surgery on the disease right now, or maybe not even in the coming coming time.
Okay, but we can cure it.
I absolutely, really wished we could have done that for you. That I would not keep you in dark, and that's really not the case right now.
Okay, I get it.
Okay, so could you please just summarize it for me? What could you understand with all this conversation?
I think you said more of chemo right now, and I could come back to you with my wife, and then we can go more about what is to be planned next. She would also like to know.
Yes, absolutely.
And
Because
I would like medications to help me with the pain and sleep.
yes, we can definitely do that. So I think my pain and palliative care specialist would help you with the pain medications, and we hope to get your symptoms definitely better, and we will aggressively work for that.
Okay. Thank you.
Sure.
Thank you, Doctor.
Okay. Oh, there we go.
Yeah, excellent.
Thanks. So this was the scenario here when we had more time for the patient. Anybody who wants to say any difference between the two scenarios? Dr. Summer, would you like to comment? Dr. Abhijit, sir?
Yeah, there was a difference.
Yeah. What difference, ma'am, could you make out if you could just?
Yeah, there was a lot more empathy. Whatever points you enumerated in your first, where you were lacking, you took care of that. That points you gave. Your body language also changed. Your attitude towards the patient, and that you both of you depicted very nicely.
Thank you.
Thanks.
Thank
Yeah.
you.
Vijay?
I don't know how much we tried in the whole case scenario, but the whole important point we wanted to focus was on communication. And I think the concept has changed from just talking to communicating. So it's more about engaging yourself into the communication, actively listening to it. And I think, I mean, that is the key difference between the two scenarios. When you are actively involved and engaged into the conversation and taking part into each and every aspect of care which is involved with the patient.
True. The bond of faith should be established in between the patient and the doctor, and that has been done quite nicely in the that faith, it should get established that whatever you are doing for the patient, it is good for him or her, whatever.
Yeah.
Yeah. Mela, if you could actually stop sharing the screen, then
Just one more moment.
okay.
So I'll just give you a few more helpful tips. I actually already mentioned those. So active listening and ask, tell, ask, right? So this is very important. Normally we do tell, ask, tell. So we tell first and then we ask. So always ask and then tell and ask. Then there are a few helpful phrases which I mentioned and I use some of them. So we do ask, tell, ask in our spikes technique as the perception and the invitation. Then helpful phrases, something like, I wish things were different, tell me more, and setting the goals right as to, in this case, setting the goals to pain management and management of sleep, those things. Then one important thing to emphasize is what phrases we should avoid. What do you want us to do? So patients are not empowered enough to answer that question. What do you want us to do? Always give them only few choices so that they can make their choices, and they should be informed choices. They don't know what we can do at that point, right? Then withdrawal of care. Don't use that word that we are withdrawing the ventilator or pulling the plug. So those things are really important, and choosing the words wisely is very important. Then as palliative care rightly says, there's never it is that we have nothing more to do. So never use that thing, because palliative care always offers hope. Then another important thing is, do you want us to do everything? This is a very commonly used phrase. Do you want us to do everything? So for patients, they don't know what is everything, right? And there's nothing called everything. So always tell them what are the options with them, and what we can do, so that they can make right informed choices in right time. Then always get help, right? It is a very, very difficult scenarios. Such communications are not as easy. So always involve your team involve your palliative care specialist in these communications. Medical oncologists might not have time to do all this stuff. So involve your palliative care specialist early. They might be able to help you out in these difficult communication. Then involve a psychologist. Sometimes if there is very difficult scenario, as in patient is in complete denial or very angry, so those things we might require help from a clinical psychologist also. Then pastoral care, we don't really have it in our hospital, or I don't think any of the Indian hospitals have it. So, maybe some religious guru might be able to help them with the questions like, why me? Why has it happened to me? So those things. Then ethics consultation, sometimes we don't have it in our setup, ethics consultation. So might have some ethical committee or internal board who can communicate those things to the patient, right? And so, yeah. That's it, I think. That's about the summary. Summary is communication is actually a learned skill, right? So we can all learn it. We were not born, nobody's born with good communication or a bad communication skill. So we can all learn it, and there are ways to improve on it. We can practice and send feedbacks with our friends and colleagues, and always use an organized approach. When we are organized in our mind as to spikes, okay, we first set, perceive, invite, and do it. It is much more easier to do rather than just haphazardly starting it from anywhere. Words are very powerful. Please choose them wisely. One bad word and it spoils the relation. So, and utilize the resources around you. Utilize your palliative care specialist. It is very important for all of us to do that. Thank you so much. And here I stop sharing my screen and hand it over to Dr. Abhijit Dham, who is our medical director of the Hospice Koshish, a very, very passionate palliative care worker. And it's always a privilege to hear him. Welcome, sir.
Yeah, thanks
I
a
think
lot.
before we actually go on to Abhijit, I think it's very important to actually thank you, Megha and Gaurav. I think this was an excellent session. Something I think we need to do more often. I actually love the way you use the mnemonics, especially the spikes and nurse, and how you actually used spikes in your, when you did the second time to do it better. I think we could make out that you're using all aspects of spikes. And I think, again, I think most important part, I think, okay, fine, chemotherapy, radiotherapy, or treatment part, that is okay. With that, I think most people can do it well. But communication is where people actually lack. You're very right. I mean, those words which you should not use or which you should use, I think they need to be emphasized more in these. And I think we need to actually have more sessions like that for people to actually understand how important communication is. Not only in palliative care, I think even day to day, how you actually do your pre-op clinics or when you go and see patients. Patients are equally stressed having a operation. Imagine a child having an operation and parents with them. Can you imagine the stress they go through? Yeah. Isn't it, Bijay?
Absolutely.
Yes, absolutely. Yeah, it's very important, everyone.
It not only applies in the medical practice, it also applies in our day-to-day work at home, at a workplace, everywhere. I think the way you communicate yourself, I think it matters a lot in entire workplace, and even at home, I would say, it is really important.
Especially with children. Children pick up good habits and bad habits more easily than good habits. The another one thing I need to actually tell, there is actually a lot of stress and communication in at least in the western part, at least in UK. I think they are. We actually say that in UK the medical students may not know how to do a procedure, but they know how to break bad news. Okay, so that is actually taught. They're still taught. I think which is not done in India that well. And I'm actually happy to know you mentioned that it is being done now as part of the MCI new curriculum.
Yes.
I think everybody is waiting to hear Abhijit. So let's get on with Abhijit's talk, and then we can have a discussion, a group discussion after Abhijit's talk.
Yes.
Over to you, Abhijit.
Thank you, Shiv. Let me share my screen. Is it visible?
Yes, it is. Yeah.
Well, after those two excellent lectures,
I really don't know how much I would have left to say. But having said that, it's been almost 2 decades since I've been practicing palliative care, and that too in resource-poor settings, mainly in tribal settings in Jharkhand and adjoining parts of West Bengal. So when I actually started off my practice after learning a lot of palliative care, very much bookish knowledge and training in Poland, and when I actually went to do palliative care in those resource-poor settings, I had gone with the idea that I would create a change, I would bring about a big change in the people out there, in the conditions that they lived in, because that was my idea. But strangely, over a period of time, instead of bringing about the change in them, there was a huge change in me. And Shiv can vouch for that. What I was way back in 94, 95 at AIMS, and what I am now, there has been a change and I feel it. Well, having said that, the concept of what we call a good palliative care. So what do you mean by good palliative care? By good palliative care, over the years which I have been practicing, what I mean by good is availability of your palliative care services and resources. By availability, I also mean a consistency in availability. It doesn't mean that you are available, say, just one day a week. No, you have to be consistent in your availability and optimal use of resources. Often we say that, oh, I don't have access to this, I don't have access to that. But then please do question yourself, have you actually used all the resources which you have locally? Right? So optimal use of resources. The second factor is accessibility. Whenever you're prescribing any drug or prescribing any therapy, be sure whether the patient can access it. Third is affordability, which is a big issue in India. It's a really big issue, and especially in rural belts, it's a big issue, affordability. And the final is acceptability. Have you ever thought why those jhola chhap doctors are actually more popular than you? Those jhola chhap doctors who practice in those little villages and those little towns, they are more popular, they have a better practice than you, because they understand the local culture, they understand, they blend with the family. You never get to visit the family. You just sit in the comfort of your office and talk to the patient. But when you go down to the house of the patient, see the conditions in which he lives in, see his state of social affairs, only then you can have an idea about his expectations, his joys, his sorrows. So acceptability of whatever care you give is an important thing. So as I said, the land, the people, their culture, the local beliefs, the practices, all this becomes very, very important. And I said, I went there as a teacher, but I became a student, because these things which I had absolutely no idea of, and then I began to learn. And not only learn, I was transformed. And if I had not undergone that transformation, it would just have resulted in a state of fighting. So the basis, what I advocate is that the backbone of good palliative care is a home-based palliative care. Put yourself in the shoes of a dying patient who knows that he is terminal, just a few weeks or a month to live. And would you really like to be lifted up and taken to a hospital, put in an ICU? Or would you like the doctor or the nurse to come down at home and provide comfort-based care? So ask yourself that and you will have the answer. So when I started off with my own practice, I had to face a lot of problems because it was a virgin society. Nobody had an idea or inkling as to what palliative care really meant. So whenever you go down to a village suddenly, and then you provide free services, and actually you give medicines also free of cost, immediately you are viewed with suspicion, because they would say कि क्यों आया है भैया, मकसद क्या है इसका, जरूर कोई मकसद होगा. And then there is a lack of awareness. non-cooperation from the authorities, they are not bothered. The authorities are not bothered about palliative care because they don't even know what it stands for. And then there is the lack of availability of morphine, which I'll come to later on. So this is how the situations are when you get down to a village and actually go down to the village. And this is how the villagers, you see the looks on their eyes, very suspicious looks they are giving you. And they are in no way related to the patient. The patient is inside that hut, in that green sari. That is the patient. Accessibility. People have to make a lot of effort to actually reach you. Have you ever imagined what it is, what happens to a patient who comes to your OPD? Maybe he has been making plans of coming to your OPD since the last 1 week. And then he has been collecting his money, he has applied for leave, and then he can't walk and he has called his rickshaw wala, and the rickshaw wala usko CD se utarta hai niche, rickshaw mein bithata hai. Then he catches a bus, comes down to your OPD. He has dressed up in his best clothes. He actually has taken a bath that day. He has put on powder also, so that he's presentable, you know. And wo aata hai doctor sahab ke paas, and as you have seen in that bad communication role play, the doctor hardly even looks at him. But have you ever considered the amount of effort that that poor patient has put in just to come to you and make himself in a, you know, come to you in a presentable condition? That is what matters. So that is the learning. That is the learning. So people travel long distances in very desperate conditions to actually reach you. And when you reverse the thing, and this is how we reach the patients. तो मुझे पता है अभी दर्द. हम जब जाते हैं पेशेंट्स को देखने, and this is how we go. And this is during the winter months, जबकि बारिश नहीं है, तो ये नदी पार हो पा रहे हैं. बारिश का मौसम में तो सवाल ही नहीं आता नदी पार करने का. So when you reverse the situation, then you understand दूसरों का दुख क्या होता है. The local culture, their local practices, ghungat is a very important thing. And as Megha said, that you have to be in touch. The cultural appropriateness of touch is again very important. Just because भैया वो अंग्रेजी किताब में लिखा है कि touch the patient, touch करोगे भैया गांव में तो बड़ा दिक्कत हो जाएगा. So you have to be very, very, very careful, and your touch has to be culturally appropriate. And there are certain so-called safe areas where to touch the patient, right? Communication skills. Well, Megha and Gaurav have, you know, done an excellent role play and everything. But then over the years, what I learned was the logical approach. अब ये देखिए, this is in the Purulia district of West Bengal, one of the poorest districts in West Bengal. एक गांव में हम गए थे in 2009. You see the date, 2009, 10:24. मैं थोड़ा पतला भी था तब, एक्चुअली सर पे बाल भी थे ज्यादा. तो मैं बैठ के आई वाज टॉकिंग टू दिस लेडी, सीए सर्विक्स, वेजाइनल डिस्चार्ज हो रहा था, काफी दर्द था कमर में. तो वेरी प्राइवेट टॉक्स, यू नो. सो 10:24 पे मैं आराम से बैठ के उससे प्राइवेसी में बात कर रहा था. और देखिए 10:40 होते होते कितने लोग जमा हो गए. तो क्या करेंगे आप? इन लोग को भगा दीजिएगा. These people are the well-wishers. यही लोग हैं जो पेशेंट के साथ रहेंगे. जब तक ये जिंदा रहेगी ना, इन्हीं लोग रहेंगे. They are the well-wishers. You are the foreigner out there. तो आप मैक्सिमम क्या कर सकते हैं? At that time you have to stop the conversation and postpone the conversation. So this is how you have to go about it, because privacy, if you see the spikes protocol, उसमें you need that privacy factor is very important. But यहाँ applicable नहीं है भैया. Because this is how you have to adapt yourself to various cultures in India. See again, another setting in which we were examining a patient at the home. वो उसको बहुत अच्छा लगा कि भैया बाहर से लोग भी आए हैं, तो टेबल कुर्सी मंगा के हम लोग को दिया. बट देखिए बाकी गांव वाले सब जमा हो गए थे. Because they are all interested. It's not that they have come with a bad intention. They have come with their compassionate presence कि भैया मेरे बगल वाले को आप देखने आए हैं तो क्या देखने आए हैं, जरा मुझे भी पता रहना चाहिए कि क्या आप क्या करने वाले हैं उनके साथ. Because the village dynamics is a different type of dynamics. वहाँ अगल बगल वाले, they know everything about each other's families. It is like a large family, you know, unlike what happens in the apartments in, you know, large metropolitan cities. Then domiciliary based interventions. Now, suppose there is a patient in a remote village who has ascites, for example, you see, ascites, malignant ascites. अब इसको हम बोलेंगे कि भाई अस्पताल लेके आइए, वहीं ड्रेन करेंगे हम, तो नहीं होने वाला है, वो तो कभी आएगी नहीं. She will die definitely and she will die in suffering. So from a medical ethical point of view, you might say, अरे भैया ethically आप कैसे कर ले रहे हो? But I am going to use the first ethical principle, you know, of medical ethics, which I say is non-maleficence, and second is beneficence. So non-maleficence is first, please do not do any harm, and then comes beneficence, that is, please do some good. So with adequate explanations and explanation of the possible risks also, you have to relieve their suffering with whatever you have. अब you expect कि भैया I need a sterile environment and everything. Yes, you can achieve that. You bring your gloves, bring a IV cannula, and घर में जो कटोरे हैं ना स्टील के, प्रेशर कुकर में डालिए, सीटी मारिए, ऑटोक्लेव हो गया. You can relieve the suffering. You have to do it then and there. Common sense जो है ना बड़ा uncommon है, but उसी को फिर you have to rely on that. जो theoretical knowledge है, that is fine, that forms a base, but then you have to keep on adapting when you are down in the field. See, here I'm doing a pleural tap, which is potentially dangerous. I didn't want to do it, but this female was so dyspneic that I had no choice. I explained the risks and she said yes, and the person who is sitting in front of her holding on to her is her husband. So when the husband is holding on to his wife, and every time the wife looks up, उसको दिखता है उसका चेहरा. She sees her husband's face, and उससे उसका confidence भी बढ़ता है. And then I ventured to do it. Again, a ascitic tap. But what is important in this picture is this lady who is acting as the chair rest, as the back of a chair, and that is our volunteer. So you see, palliative care is a team approach. ये आप अकेले हीरो जैसे नहीं जा सकते हैं. You have to go as a team, and every member of the team is important. So the volunteer who is actually sitting there, that lady who is acting as the chair rest so that the patient can actually lean back on her, she also has a very important role to play. And then there are so many things which you can actually do at home without any special, special anesthetic technique की जरूरत नहीं है. When you are doing a eschartomy, this was done in an elderly lady, bed sore था, and there was an eschar. Eschartomy, the black eschar tissue is dead necrotic tissue. It is a painless procedure. You can do it at home. And in India, people just talk of cancer. Palliation means cancer. वैसा नहीं है भैया. The single largest group requiring palliative care is the elderly. Palliative care हम सबको लगेगा. Even in this COVID times, I have given palliative care to patients who were actually dying of COVID. It is tough, but then palliative care becomes important. Children with cerebral palsy, COPD, you know, who are oxygen dependent, or chronic renal failure. And then there is something called technology versus innovations, right? Now, technology, medical science, जो है ना, it has increased by leaps and bounds. काफी advanced हो गया है. So, but what has this advancement given us in actual terms? देखो, I always say this in most of my lectures. I mean, people get bored with this dialogue of mine, but the only guarantee, भैया, the only guarantee which you have in your life is your death. है या नहीं? तो भाई अपने मृत्यु के लिए कुछ इन्वेस्टमेंट तो है नहीं आपके पास, नहीं आप करते हैं कुछ. So investing in your death or even thinking about your death sometimes becomes important. क्यों? क्योंकि this medical technology has increased by leaps and bounds. And what it has achieved? It has achieved a lot. It has made the process of dying more painful, more prolonged, lonely, and very expensive. This is what modern technology has also given us. It has given us a lot of good, but with the good, कुछ खराबी भी आ जाता है. So technology is fine, but you need to innovate. One innovation, the greatest innovation is palliative care. Plan your death, plan your dying. Where would you like to die? How would you like to die? You can have some frame, you know, some frame, write it down. Advance directives, लिख के रख दीजिए भैया कहीं छिपा के. So at least you'll die with dignity. Now, ये बच्चा with cerebral palsy, he can't walk. So if we had to buy an expensive walker for him, तो वो walker would have cost something like 45 to 50,000 bucks. But ये जो लकड़ी का जो खिलौना है ना, most of the young doctors wouldn't have seen it. हम लोग बचपन में खेलते थे इससे, धक्का मार मार के. तो इसके पिताजी इसके लिए ये बना दिए, and इसी के बलबूते वो चलता है अभी. So it is not always that technology or innovations have to be expensive. It can be quite cheap and locally available also. CA breast, काफी advanced. तो इसका this lady, इसका जब हम लोग ड्रेसिंग करते थे, it used to take us a couple of hours. और ड्रेसिंग करने के बाद the dressing used to be so tight कि ड्रेसिंग के 2 या 3 घंटे के अंदर वो पूरा ड्रेसिंग फाड़ के बैठ जाती थी. Because ड्रेसिंग इतना टाइट रहता था, she could hardly breathe. So this was what she looked after the dressing, you know, all banded up, and she could hardly breathe because of the tightness, you know. तो फिर हम लोगों ने फिर अपना दिमाग लगाया, भारतीय बुद्धि. So we came up with the sanitary napkin. Excellent thing. It can soak up a lot of fluid. Just 2 napkins would cover more than 90% of the whole area. Just strap it with micropore and voila, you have a very light dressing. Extreme circumstances. काफी इंटीरियर वाला विलेज है, वहां कुछ नहीं है उसके पास. केले का पत्ता या any fresh leaf, cut it, you can use it as a dressing material. हल्दी पेस्ट you can use, yogurt you can use. शहद लिखा हुआ है भैया, शहद हम लोग को मिलता ही नहीं है, ऐसे वो भूखा आदमी है, शहद कहाँ से मिलेगा, चावल नहीं मिलता दिन भर का. तो बट हल्दी मिल जाएगा. So हल्दी पेस्ट you can apply. Now another example. अब ये औरत विधवा, भारत में विधवाओं का हालत आज भी काफी खराब है. आज से 20 साल पहले तो बहुत ही खराब था भैया. जो गाय दूध नहीं देती है उसको लोग भगा देते हैं, दूर कर देते हैं घर से. तो विधवाओं का वही हाल था, बट इट्स इम्प्रूविंग. सो बट ये विधवा, शी वाज लकी. CA cervix with pyometra, ड्रेन हो गया, एंड शी यूज्ड टू स्मेल अ लॉट. तो छोटा सा इनका घर था, तो उसका घर में परिवार के 5-6 लोग थे, तो वो स्मेल के चलते कोई सो नहीं पाता था. तो उसका बेटा क्या किया, माँ का चारपाई उठा के उसको आंगन में रख दिया, जहां गाय भैंस बांधते हैं वहीं रख दिया. अब वो मजबूरी में किया भैया, he had no choice because otherwise the family couldn't sleep. बट ये रोज आके हमें बोलता था कि मेरी माँ सो नहीं पाती है. तो हम लोग को लगा भाई सो नहीं पाती है, क्या बात है. तो मे बी इट इज पेन किलर्स दे रहे थे, तो और क्यों सो क्यों नहीं पाती, एंजाइटी, एनीथिंग ऑफ दैट सॉर्ट. बोले नहीं खुश है अदरवाइज. एंड देन वी विजिटेड हर, और फिर हमें पता चला कि सो क्यों नहीं पाती है. यू कैन सी द हाउस फ्लाइज, दीज प्रिवेंटेड हर फ्रॉम स्लीपिंग. तो दिस गिव्स अस द इम्पोर्टेंस ऑफ होम विजिट. इसको सिर्फ 100 रुपए का मच्छरदानी हम लोग खरीद के दिए. इसको we could have prescribed benzodiazepines or falana dhikana and all that, none would have helped. So this undermines the importance of home visits in palliative care. Unless you visit the patient at home, you would miss this. And this is in the suburbs of Kolkata. This is in South 24 Parganas district. I used to go there quite regularly for patient visits, and I used to hire a car. तो ये जो गाड़ी मैं हायर करता था, that used to double up as my clinics. तो लोग बाहर खड़े रहते थे. I take the patient, put him inside the car, shut the door, examine him, talk to him, and उसके बाद open the door, वो patient बाहर हो जाता था, next patient would come in. So मेरा mobile clinic बन गया था. So you continuously have to keep on innovating. As I said, the team approach, आप अकेले हीरो नहीं बन सकते इसमें. All the members of the team are important. So this is what our team is. You have to motivate the people around you to help you, because आप तो at one point of time जाके वापस आ जा रहे हैं. सोच लीजिए काफी इंटीरियर वाला विलेज है जहां पहुंचने में आपको 2 घंटा लग रहा है. There you empower the local youth, right? Once you empower them, they will do the further care. Like ये बूढ़ा को, ये 2 लड़के को empower किए थे हम लोग. इन लोग रोज इसको झोपड़ी से बाहर निकालते थे, धूप में बिठाते थे, उनका ड्रेसिंग करते थे, और फिर उसको शाम होते होते अंदर फिर झोपड़ी में लिटा देते थे. अकेला बूढ़ा था. He just lived for barely 1 month, but that 1 month we could give him a good quality of life. Now, as I said, morphine, bhaiya. Now, there is a very large institute in India. I won't name it, a tertiary care hospital, and they actually refused to refer patients to me because they said that you don't have morphine. That is why we will not refer any patients to you. See, morphine is a drug which is used in WHO step 3, right? But you should remember that most of the pain, the chronic pain, 90%, almost 90% of the chronic pain can be handled without even going to morphine. If you use the drugs which are commonly available over the counter in a proper fashion. You have NSAIDs, you have tramadol, codeine is probably coming back again, dextropropoxyphene is coming back again, right? And then you have pentazocine, you have nalbuphine, so many things you have. And then you have the patches, ubiquitous patches, buprenorphine patch, fentanyl patch. अरे मजे की बात ये है कि morphine available नहीं है tablet, but fentanyl patch आपको मिल जाएगा भैया. So see the economics involved and the big hand of the pharma companies guiding the whole, thing. So working without morphine, people used to label me as the black sheep. भैया इससे होगा नहीं. So oral morphine is fine. I agree. Morphine is important. Stepladder 3 mein it is important. But then you should also understand that when it comes to chronic pain, physical pain accounts for hardly 25 to 30% of the total pain. Just 25 to 30%. And all this pharma industry is just focusing on that 25 to 30%. They don't want us to focus on the rest, on the 75%, which is social pain, spiritual pain, and psychological pain. They don't want you to focus on that because economics are involved. So think about what you're being forced to do, and think about what a zombie they have made you. So just don't be like this white sheep, one sheep jumps over the fence and all the sheep follow it. Even if you remove the fence, they will keep on jumping like that. So do justice to the other components of pain, psychological, social, spiritual. And मैंने स्टार्टिंग में बोला था कि वो झोला छाप डॉक्टर जो है ना, वो बड़े ही कमाल का प्रैक्टिस है उनका. They have a better practice than you because they use injections. जहां मौका मिला वहीं एक ठूस दिया इंजेक्शन. now गांव वाले जो है एंड काफी शहर वाले भी, जब तक इंजेक्शन नहीं देगा डॉक्टर, वो डॉक्टर नहीं है, वो छोटा डॉक्टर है भैया. So that is a cultural thing. Don't laugh at them. It is not that. So whatever we have learned that use the oral route, it is fine. I agree totally. But then you have to focus on cultural, psychological factors as well. So if the patient believes, has a conviction that मुझे जब तक इंजेक्शन नहीं पड़ेगा मैं ठीक नहीं होऊंगा, दे दो भैया. This is my take on it, my personal take. And we do give, this is how we treat patients in their own homes. We prefer them to die at home. This is in a jhopdi. This person is clearly dying. And then there is a Grasby pump which was donated by a hospice from Scotland. Actually, you know why they donated it? Because they were phasing out this syringe pumps. They were getting newer batches, so the old ones they just phased it out to us. But then these pumps are not suitable for the Indian environment, because it's hot, humid out here. So the pumps jam up very frequently. So it's better that you give intermittent subcutaneous injections. You drop the drugs in a syringe, जैसे यहाँ दिख रहा है, and explain it to the family members. आप syringe में बना के दे दीजिए patient के family members को, put in a subcutaneous port and leave it out there, and tell them कि ये दवा हर एक 2 या 3 घंटा whatever interval you want them to be, 1 cc या 2 cc आप उसमें से push कर दो. तो उससे क्या होता है? The patient feels कि देखो ना, कंट्रोल तो मेरे घर में आ गया अभी, दवा का कंट्रोल. मेरी बीबी दवा दे रही है मुझे, तो जरूर तो मैं तो बढ़िया हो जाने वाला है. So that conviction comes. That is important. Treating the mind is very important. So empowering. This is my favorite slide. This is how I would love to die. As you see, this patient is dying. That lady who's lying on the चारपाई, she is clearly dying. वो जो पानी पिला रही है ना, वो उसकी बहू है. The last, in fact, after this photograph was taken, just a couple of hours later, the lady passed away. और वो धोती पहन के जो आदमी खड़ा हुआ है, सफेद धोती, that is the husband. And then all the family members and children are all, standing all around her. And you can see the rays of the sun are streaming in gradually. Rather, I would say उसका प्राण निकल रहा है, streaming out. प्राण निकल रहा है भैया. मैं तो वैसे ही बात करता हूँ आजकल, because I do believe that there is something beyond. Empowerment. Again, the family, the wife giving ketamine, oral ketamine to the patient, sublingual instillation of oral ketamine for breakthrough pain. Dyspnea. The most important management in dyspnea, the first management is non-pharmacological management, and the most important management is reassurance. जब एक आदमी का दम फूलता रहता है तो उसे डर लगता है कि सांस अटक के मर जाऊंगा, that I will choke to death. You need to reassure him. एक पंखा चला दीजिए, खिड़की खोल दीजिए. Simple things. Don't leave the patient alone. Right? Shared decision making. गांव में कोई भी अकेला decision नहीं लेता. It is all shared decision making. So you can see that lady who is sitting on the chair. She is the patient and her husband is sitting next to her, and it was discussing a significant, important decision regarding end of life care. And you see all the family, extended family and the neighbors, everybody is around, so that you are also safe, because मैं सबके सामने discuss कर रहा हूँ, and it's a collective decision. Advocacy. Well, palliative care, this photograph was taken way back in 2007, and you can see Jilly Byrne in that pink sari, she's sitting in the middle. And during this occasion, we actually trained 100 NCC cadets. Not trained them, but we sort of gave them an insight into the concept of palliative care. And then this was way back in 2008 when I had decided कि palliative care, और वो भी भारत में, ये समझने के लिए मुझे खुद, जैसे गांधी जी गए थे ना डंडी यात्रा, but I am very lazy, so I chose to drive. But I chose a car, and believe me, एक पैसा किसी ने नहीं दिया. I approached certain very rich hospices which could have easily thrown some money at me. एक पैसा किसी ने नहीं दिया. तो we drove in a car, and एक सरदार था और मैं था. So we drove through all those little roads of India. We planned a hospice tour India, but पैसे नहीं थे, तो we just could cover 7 states of India. सुबह 6 बजे गाड़ी चालू करता था और 10 साढ़े 10 बजे एक बार गाड़ी रोकते थे ढाबा में. तो ब्रेकफास्ट और लंच इकट्ठे खा लेते थे, पैसे तो थे नहीं. और फिर गाड़ी चल देती थी. वी यूज्ड टू स्टॉप एट एवरी लिटिल विलेज. छोटे शहरों में पैम्पलेट्स डिस्ट्रीब्यूट करते थे, लोगों से बात करते थे कि भाई पैलिएटिव केयर ऐसा ऐसा चीज है, आप सहमत है क्या इससे. एंड देन इसका नतीजा ये मिला, भूख. भाई जब खाली पेट में आप पैलिएटिव केयर के बारे में आप सोचेंगे नहीं. जब पेट भरा रहेगा ना तभी आप आदमी पूजा करता है. खाली पेट में पूजा तक नहीं होता है. So unfortunately in India the priority is not palliative care. In India where there is poverty, death is most welcome because it means a mouth less to feed. कोई मर जाता है तो बाकी लोग को खाना थोड़ा ज्यादा मिल जाएगा. So that is why in my hospice I have started feeding. And this has been my practice since more than one and a half years. And most of the members of the anesthetist group have helped me. And I'm thankful to them. Because आप सबकी मदद से ये बच्चे खा पाते हैं. We ensure that they get at least 3 good meals every week, minimum of 3 good meals every week. And now we have extended this program to the rural elderly also. अब घर घर जाके हम लोग वो जो बूढ़े घर में पड़े रहते हैं उनको सत्तू देते हैं. Now सत्तू is almost a complete meal. And उसको अलग से बनाने की जरूरत नहीं, आप सिर्फ पानी में घोल दीजिए and you have a fantastic complete meal. So care of elderly, organizing health camps for rural elderly, compassionate presence and compassionate practice is the hallmark. Home care again. Abhi winter is coming, puja is coming. We will start our distribution of blankets and clothes. And then spiritual issues. Megha was discussing about pastoral care. Well, spiritual issues, and we do it in a big fashion. ये जितने छोटे छोटे मंदिर या मस्जिद या गिरजाघर जो है ना, these are centers of research. समझे? वो बड़े बड़े इंस्टीट्यूट्स में रिसर्च नहीं होता है. ये छोटे छोटे जो मंदिर गिरजाघर है, these are centers of research. क्यों? जब आप वहां जाते हैं ना तो आप अपना दिल खोल के वहां you open your heart and then you talk. You don't talk to somebody, you talk to God and you talk with your mind. So these are areas of research, self-search. So spiritual issues are a big thing, big thing. So we make things happen, and this is my guru from whom I learned the art of palliative medicine, Professor Uchak from Poland. So we help to make things, we help to bring back that little smile. This lady with advanced malignancy, she wanted to hold her great-granddaughter before she finally died. We made it possible. Little things like religious things like, Ganga Jal pilana. Pilane do na bhai. You might say, Ganga Jal kya pilate ho? Ganda pani hai. अरे यार तुम्हारे लिए गंदा है, उसके लिए तो फेथ है भाई. Faith can move mountains. So there are a lot of stories to tell, but I think time is not on our side. And I'll just give you a running thing. This guy, ये जो नीचे बैठा हुआ है ना, he is our compounder, the pharmacist. Pharmacist यहाँ पलती मार के नीचे बैठता है with the drugs spread all around him. Because when you diagnose a condition and prescribe medicines, you are just doing 50% of the job. Baki 50% is when the patient takes the medicines and buys the medicines and complies to the intake of medicines. So he has to take the medicines in the way it is being prescribed. वो उल्टा पुल्टा medicines खाएगा तो असर नहीं होगा. So everything goes waste. So this is where it is very important to explain to the patients what to take, how to take, in their local language. We practice this. आराम से बैठो. उन लोग भी पलती मार के नीचे बैठते हैं. लोकल लैंग्वेज में बढ़िया से समझाया जाता है कि लाल गोली दिन में 2 बार लेना पड़ता है. तो तुरंत पूछेगा खाना खाने के पहले की बाद, तो वो भी समझा दीजिए भैया. ठीक है. So this is the interior of a hospice. It's mostly empty. Because I do believe that the best hospices in the world are ones which are really empty. Because your peripheral services are good. That means your home care services are good. Children, as I said, we do feed the children, we help teach the children. So when you start doing palliative care, you gradually begin to understand that it is not just the physical entity which you're treating. It is more of a social thing, a spiritual thing, a cultural thing. So एक से दूसरे पे जाते हैं, दूसरे से चौथे पे जाते हैं, and it starts spreading. Music therapy is an important part of therapy, right? Like massage, simple massage therapy. जब माँ के गोद में लेटते हो ना और माँ सहला देती है बाल, बड़ा अच्छा लगता है ना. बुखार जब आता है तो वो पैरासिटामोल वो आराम नहीं दे पाता है. So the power of touch should not be ignored. Life is a celebration. Age is just a number. And all said and done, at the end of the day, remember that you should take care of yourself, because you cannot pour from an empty glass. So you should be aware of the concept of burnout and take care of yourself. That's it. Thank you.
It's always wonderful to listen to you, Abhijit. It's, I don't know, it brings tears to my eyes every time. And these tears are not of, it's not of sadness or thing, but also of happiness that at least there is someone who is actually looking after these issues, and that too in rural areas where people have no one to actually reach out to, and you're able to do that. Absolutely wonderful talk, wonderful insight into what exactly palliative care is. And I think you covered lots of points. It's not just about medicine, it's just not about hospital care. It's about, recognizing what people actually think about it, how you can use the local culture, how can you use the local resources. That's absolutely wonderful, and nice to actually see that you're not only looking after the patients and their home, but also the children. We always follow your all the recipes that you make for them. You actually feed them. They just enjoy it. I think that's the joy. That's the joy. And I actually wish to actually visit your place anyway. Sometime.
You're more than
after COVID.
welcome.
Oh yeah, after COVID, I will surely visit.
It will be a pleasure.
And spend some time there. Yeah. Rest of the faculty can come in, and we can actually have a discussion on whatever questions you have or whatever points you want to make. Megha, somebody, the rest
So
of
I think Dr. Abhijit, it was really so, we get touched by the things, because we being in metros and, always working around in corporate hospital, do not really get to see that aspect of palliative care. So, which is indeed, I mean, the maximum and the major chunk of palliative care that India needs at any point of time. So yeah, it was really a moving talk for all of us, although we all keep listening and, we keep getting the data as less than 1% in India getting palliative care, all those things. But when you actually see those pictures, you get the insight of, okay, right, this is what is happening around there in suburbs of our country. Yeah. Thank you so much, Dr. Abhijit. It's always a pleasure to listen to you.
My pleasure.
Dr. Samar, anything?
It was an excellent talk, Avijit sir. I am following you for many years, and you never fail to amaze us with your, the Desi Jugaad or the other approaches. It's not only palliative care per se. You are teaching the children there and feeding them. Excellent job. Salute, sir. Salute.
Thank you.
Yeah, I think at this moment, Abhijit, I would like you to actually also share the link to your Koshish, so that people can actually donate. And you want to put it on the screen for some time, that'll be great. I'm sure there are a lot of people who would like to actually contribute to the cause.
I'll put it up on the group sort of thing. It's just
No, you can put
Koshish.
it up now as well. It will be part of this because this is on YouTube, so it's going to remain. And then just a little bit of about it. Just leave the the
Dr. Abhijit,
Yeah.
uh,
Pranam, sir.
Dr. Vaikar, I have been following you on FB and I'm really impressed. I just wanted to ask you one question. What was your inspiration behind all this things? Behind starting this?
I basically got into anesthesia because I wanted to do intensive care. That was something which was my passion. I did my house job in general medicine, and then I went into anesthesia basically for getting into intensive care. And then, over the years, watching patients die very lonely deaths on ventilators, while their relatives are just standing beyond the closed doors, just maybe 20 feet away. I somehow felt that this was not the way to die, actually. I mean, people deserve a better death. So that sort of prompted me to relook, have a different perspective into things. And so then I branched out.
I'm sure all the faculties as well as the people who are listening to this must know one name in palliative medicine, that is Rajagopal, Dr. Rajagopal from Kerala. He's known to be a father of palliative medicine. And I was so fortunate that his hospital and our hospital in Trivandrum were just side by side. And I had an opportunity of interacting with him. Extremely humble person, very soft spoken, never raised his voice, and very concerned person. And now I think he was nominated for Padma Shri or something like that.
Yeah. He's already got it last year.
Yeah. He's a great man. I mean, there is no question about it.
Absolutely.
He's a real inspiration for majority of the people who are working in this particular setup. And they all work without any remunerations. That is the most important thing. And he has, it's unbelievable how he has started this and how he has made it very, very popular. And that's
he was in a medical college. He's in a medical college, isn't it?
He was in he was in Trivandrum Medical College earlier.
He was in Calicut before.
Yeah,
he was in Calicut with Dr. Suresh.
Yes. Before that, he was working in Trivandrum. From Trivandrum, he went to Calicut. After
he's a pass out from AIMS as well.
Yes.
He's our senior. And and after that, he went to Calicut, and then he started the thing, and then he had he branched out to Trivandrum, and then there was no looking back after that.
Yes.
Yeah. I think when I actually came to know Abhijit, I've known Abhijit from the time he actually joined AIMS as a postgraduate in anesthesia. And quite of us friends are on the group still there. We are in all touch. When I came to know when Abhijit actually had taken up palliative care, it surprised me a lot because he mentioned that he was a totally different person. I mean, and you need a different kind of a mindset to be in a palliative care, looking after this kind of patient. So I think it was a surprise to me, but also I think a great, I felt absolutely great knowing that Abhijit has taken up this with such passion. And I think he's inspiring a lot of people who are actually now thinking of palliative care as their profession. So I think that's really great.
Yes, absolutely. So do we have any comments, any thing from YouTube, anything that we can answer?
No, I think the YouTube is not, nobody is, I think, putting the things on that. I don't know what the Facebook, it's slightly different from Facebook. So I'm using it for the first time.
Okay.
We are
Yeah.
supposed to actually, we can see, but if you want to comment, we are supposed to log into the mail, I think, email ID. So
Okay.
maybe, yeah, going to the email and then it must be difficult. Like Facebook, it's not straightforward.
Yeah, so we also have Dr. Oma, who also does palliative care in RML. Hello, ma'am. How are you?
Hello, how are you, Dr. Megha? It was really excellent to watch all of you talk so nicely on palliative care. I would just like to stress upon one thing, that palliative care training should be induced and inculcated in the undergraduation itself. None of our PGs are exposed to palliative care, maybe because of lack of training facilities or because of lack of initiative. I really do not know the reason. We can do a cross-sectional study on this, that how many colleges in India, medical colleges in India, are imparting palliative care as a teaching in undergraduate training. So this can be done, sir. I mean,
Yeah.
because very few medical colleges are there which are inculcating this practice, and it is actually a life-changing training, I would say.
It sure is.
Yeah.
It sure is. Yeah.
Yeah. It in fact changes your entire perspective, not only your professional, but also your personal.
Yes.
Yeah, Abhijit actually mentioned about morphine, and we were posted in the IRCH in Ames, and
Yeah.
all was done in a part of palliative care was actually dispensing morphine.
Oh, Dr. Shiv, don't say that,
Yeah, it was
please.
during that time. Yeah, it was.
Yeah, Dr. Abbas Saxena was there.
Yeah, it is like that. I think, but we have to actually also look at that times when there was palliative care wasn't there.
Yes.
It was just coming up field. Nobody actually knew what palliative care was, but at least patients were actually getting that. But that is
Yes.
how things actually over the years this is developed. But it did start off with actually looking at the pain aspect of it. Actually, somebody was talking to them. I think that is also important, that they were able to come to a clinic, visit a clinic, somebody was talking to them, somebody was dispensing, they would come back, they will actually have an appointment card. I think that is also an important part of the whole aspect.
Yeah. And now the same IRCH has a huge team of around 23 residents or so. They have started MD in palliative medicine, and it's a great thing now. I mean, when we were there in IRCH as senior residents, we were only 7 residents. So taking care of the OPD and IPD and ICU and OT. And now they have, I think, more than, I don't know, 30, 40 residents with them. So yeah, that is how IRCH has grown.
It has grown, absolutely. And that time,
Yeah, and the tremendous patient load is there. Tremendous.
Absolutely. Absolutely. I mean, you see patients lying outside on the roadside. These patients come from far off places. Just to think that they might actually get some respite from their symptoms, or somebody might be able to cure them. And people just look at, okay, they're going to Delhi, going to a big hospital. So most of the time it is about saying that, sorry, this is...
So one more aspect is acceptance of people towards palliative care, because once there should be more awareness about it, because once we say the term palliative, then the family members start feeling that all hope is lost. And hence they don't want to go into that area at all.
Yeah, I mean, that is one thing I actually wrote on my notes, is that what Megha said, palliative care is about hope, giving hope.
Absolutely.
Yeah,
Absolutely.
it's about giving hope. And I think that need to be like more of a word attached to, or the phrase attached to palliative care says palliative care is about giving hope. It's not about, saying that this is the end. I think that's what is seen. Palliative care is, it says that palliative care, mother, we have come to the end of the road, but it's not the end of the road. It's about saying that, well, we will like to tell you how the road will end. We will take you through the journey. It's a journey, basically, isn't it?
Exactly. It's a journey, and I mean, non-abandonment is the key. I mean, we should be with the patient, not just saying that nothing more should be done. The care should continue till the last.
Dignity. I think two other things I actually picked up from, yeah, this is dying with dignity. Obviously, that has been a big thing which Abhijit has always promoted, and he always talks about that because in Indian culture, talking about death is no, isn't it? You sit down and you start talking about death, people will actually immediately shut you off. I say, don't talk about it, like it's not something we discuss.
Yes.
Whereas it is the only thing which everybody actually, yes, everybody is going to die one day. The question is,
That's
how we are actually going to die? That's was there, and I think there was lots of things. I mean, mega talk about pastoral care. We actually, I think here in UK, it is every hospital actually have a pastor.
Okay.
Yeah, so every hospital has that. We also actually every hospital also has a multi-faith room where anybody can go and pray.
We also have it in some places, and in fact, in our another hospital of Max, we have a priest, but they are, not really trained to
Yeah.
provide that kind of spiritual care to the patient.
Yeah.
So they also need to be sensitized to the needs of the patient before they are actually able to provide that spiritual care to the
That's true.
patient.
That is very true. That's very true. I think,
Mm.
like in UK, those hospitals they actually pay for them, so they become part of the whole team, and they're part of the team.
Yes.
So and obviously, I mean, even it doesn't mean that everybody uses that service or
No,
uses that kind of.
pastoral care is a branch by itself, and soon we would be introducing something similar to that, maybe a certification or a fellowship in provision of spiritual care. We are planning to do that maybe sometime early next year. So that is that's a vacuum which needs to be filled up here as well.
Yeah, I think it's again India being such a huge country with people following all kind of different faith. It's very difficult to actually have that single or 2% or 3%. We would probably need a team of priests different from different areas to actually have that. And maybe I think for each one actually, just like we actually have a group of anesthetists, they actually have a group of
Absolutely.
that with using WhatsApp service and saying that this is a person with such and such faith, and we would need someone who can come in. I think that'll be absolutely great. Yeah. There is I think a lot. I think the very fact that we are celebrating this day today, and we never actually talked about it or never actually done this. This is itself is a good start. Yeah. And I think we should carry on with this tradition.
Sure. This was wonderful. And thank you so much, Dr. Shiv, for taking all this initiative.
Thank you to all of you. Without
Thank you, sir. Thank you very much.
I'm just a coordinator. I've just coordinated, but I think amazing talks. Amazing insight into the palliative care and hospital care. Okay, thank you everyone, and have a nice weekend, all of you.
Bye, sir.
Bye.
Bye.
Wonderful. Bye.
Wonderful, sir. Bye, everyone. Bye.
Bye.
Goodbye.